Hello, my name is Lee Presser. This is my show. I speak frequently to very interesting people. Some of these conversations are so exciting, so intellectually stimulating, I thought others might like to listen in. This is the reason we started recording Conversation with Lee Presser. Welcome to Conversation with Lee Presser. Some people have trouble sleeping, which can lead to physical as well as emotional problems during the day. Sleep medicine is now a recognized subspecialty within internal medicine, family medicine, pediatrics, otolaryngology, psychiatry, and neurology in the United States. Due to rapidly increasing knowledge about sleep in the 20th century, including the discovery of REM sleep and sleep apnea, the medical importance of sleep was recognized. The medical community began paying more attention to primary sleep disorders such as sleep apnea, as well as the role of the quality of your sleep. By the 1970s, clinics and laboratories devoted to the study of sleep and sleep disorders had been founded. Our guest today is physician Joe Ojile, founder and chief executive officer of the Clayton Sleep Institute. He is also president of the Clayton Sleep Research Foundation, an independent, not-for-profit entity performing educational and research programs in sleep medicine. Dr. Joe Ojile, welcome to Conversation.
Thank you, Lee. Thanks for having me.
Well, we're glad to have you here. Sleep medicine, you know, people don't really think much about that. I mean, the sleep medicine part, but they sure do think about at 2 o'clock in the morning when they can't get to sleep, what's this all about? We've all heard the term, you know, sleep's like a baby, but as we get older, that doesn't seem to work as well for some people. So let's just first talk about the history and how you came to be in sleep medicine, and then let's just get into what's the problem? Why are people having so much problem sleeping?
Well, thanks for the opportunity. Sleep medicine is really in its early stages of development as a discipline. It's still talking about sleeping like a baby. Sleep medicine is just, in a sense, past the baby stage in development. If you think about the other disciplines, some of them dating back to the antiquities, sleep medicine is really a creature of the last 100 years at most, but really has burgeoned in the last 50 years. So we're seeing a growth in the actual discipline of the subject as well as the science. And so consequently, over time, the technologies and the pharmaceutical interventions, behavioral interventions are maturing at a similar pace. It's quite exciting time to be part of sleep medicine.
You didn't start out in sleep medicine, I know that, because you're an MD, right?
Yes.
Right.
Correct.
And so what was your starting point as an MD?
So I started out at St. Louis University, internal medicine certified, and then pulmonary medicine. And it was my good fortune to have great leadership in our pulmonary department at that time.
Now, pulmonary, so you're heart doctor?
Lung doctor.
Lung doctor. Mm-hmm. Okay, so you're a lung doctor, and then you had great leadership, which led you to
be exposed during our training to sleep medicine. So we had faculty members that were on the cutting edge of sleep medicine at that time, some of the really giants in our field, and they got my curiosity stimulated then and have nurtured it ever since. So we've stayed in contact over all these years. It's been a really fun journey.
So what is sleep? What is it you learned? Just talk about that.
So the interesting thing about sleep is that it initially was thought, back in the early medical textbooks, it was just a lack of awake. That was the teaching of sleep, and we went on from there. And it's a third of our lives. What has been discovered in the last 50 to 70 years is that sleep's a very active, dynamic process. And over time, we're seeing the definition of that process come out. And so first of all, we define what normal is. That's how most medicine and healthcare work. And then in the ensuing years, we've looked at what derangements or abnormal is. So pathophysiology is the medical term. But as you point out, when you're a good sleeper, when you're a baby, as time goes on, sometimes bad things, either illnesses or habits, will alter that. And so, and we've now we've become able to study that through both observation, patient history, and technology. Mm-hmm. So it's been an interesting evolution over the last 30 to 40 years. Some of that coincided with some things you said in your preamble, the discovery of REM sleep about 55 years ago.
Why don't you just explain to people what that means?
So REM sleep, it's not a band. You're of the vintage that you remember that band, right? So there are several stages of sleep. There's wake, and then there's stages 1, 2, 3, and 4. And then there's what we call rapid eye movement sleep, which is named REM sleep. And during that period of sleep, the body is paralyzed except for your breathing muscles and your eye muscles. And the thing we can measure when we have all the electrodes on a person's body, or we can see that their eye muscles are moving in a certain way rapidly. So that's the term for that. The interesting thing is that's a very dynamic, physiologically exciting period of sleep. If you looked at the person's brain waves at that time appear to be identical to when the person's awake. However, their body's paralyzed, so that's how we know they're actually asleep. That's when 80% or more of dreams occur. So those are the stages of sleep. 25% or so of your night should be spent in REM sleep. So now we're able to measure abnormalities in sleep staging, depth of sleep, and start to try to put some scientific basis to how we discuss this with patients.
Is there some problem when you're not getting 25% of the 8 hours? So in other words, 2 hours of REM a night?
There may be. We think REM is a big part in restoration. So making a person feel better after they sleep. Because
I guess I ought to interrupt and
go ahead.
Say, what is sleep?
Well, yeah, what is sleep?
What is sleep? Let's just cut to the chase. What's sleep?
So we would define sleep as looking at the person, when we look at their brain waves, when their muscles, both muscle tension, everything goes down, and their brain waves slow to such a level that we can define it as stage 1, that they're no longer awake.
Okay.
That's a bit technical, but that's how we look at it in the laboratory.
But is there like a moment when you're watching your electroencephalographs?
Yes.
Is there a moment where all of a sudden you see?
They'll typically be about 30 to 60 seconds where we can see a person transition to sleep. So there is a moment in a sense, yes.
And then you mentioned that there are 4 steps before hitting REM sleep. So what's going on during, and why have we divided it into 4 steps and REM? So it's actually 5 steps.
Correct. So some of that is a bit arbitrary, right? It was defined by some of the pioneers in sleep medicine as a way to score and measure sleep. It wasn't as if Moses came down and gave us those tablets. But that definition, pardon me, typically helps us look at depth of sleep and what we would call how deeply asleep you are, how arousable your brain would be. And it has to do with the rate of brainwave activity. So we used markers in the speed of the brain waves to make that definition.
You said that this is still in the infancy though, right? So could these terms that you use today become archaic?
There is still, interesting you ask that question, our scientific academies are still changing some of the way we score tests, even today. They've issued new scoring rules issued in 2012. So the terms themselves, 1, 2, 3, 4 in REM, they don't appear to be changing, but the definitions of those terms internally is still changing.
And then you said when you hit REM, that you are paralyzed except for a few body functions. Sleepwalkers, are they the exception to this paralysis?
Sleepwalkers sometimes are not in REM sleep when they walk, but there are disorders that involve people acting out their dreams and losing that interface that keeps them paralyzed. And they're both very interesting, extremely important that they get treated, and can be dangerous.
Why is it important that they be treated, and what is the danger?
So the danger is, the good Lord was very wise in making us so we can't act out our dreams, because we're not aware of what we're doing. So if you have someone who is acting out, for instance, one of the classic stories would be someone who'd been in a war, and as they get older, that interface breaks down and they start acting out as if they were in a fight in the war, or a death battle, and they start hitting or striking their spouse. Now that person's asleep, so they think they're fighting an intruder, so they could harm both themselves and the other person in the bed, or they could walk, run out a window, go down a flight of steps, in an extreme case drive a car and have an accident. So there could be bodily harm to themselves or others. And so it's easily treated, and important that we treat those sorts of things for that safety reason.
So their eyes are open.
They can be open.
They appear to be awake.
Yes.
But if you again put the hood on there and do the electroencephalogram, you could see that they're not.
Yes, and we sometimes do see that in the laboratory, by the way. This is something that can be sometimes caught in the laboratory.
Okay. You know, this is the stuff you see in TV shows and movies, and it's some people, I think, would have a hard time believing that this is real.
But it is.
It is. And you've seen this.
We've seen it. We see it regularly.
And do people come to you? Well, let's just talk a little bit about the Clayton Sleep Institute. People come there, or you go to their bedroom?
No, they come see us as they would any physician. They would come and have a consultation and talk with us, and we will go through that history. And they leave for this exact reason. They'll come in either themselves or as a couple and say, we're a little bit concerned this is going on. And it usually is a history similar to what we just discussed, and it happens regularly.
Large number of people? Or we're talking a really, really small segment of the population?
In the scope of our whole population, it's a small segment, but it is people that come in on a regular basis. So a few patients a month with this exact issue.
And what's the process? So you sit down, you take the history, then what?
So then we have a conversation with them. If it's that sort of problem, we'll schedule a night for them in the sleep laboratory.
So they come there?
They'll come there. It's like a little mini hotel. It looks like a kind of a spa hotel. We make the patients comfortable, talk to them, and then our technicians will have them get in their pajamas and put the electrodes, which involves like a brainwave study, an EEG. A lot of glue on their hair, so we kind of prep them for that. And then, so electrodes all over their head, their chin next to their eyes, and then belts around their chest and abdomen, and some electrodes on their arms and legs.
How does anybody fall asleep with all this?
You know, it's remarkable. Most people, the vast majority, fall asleep very easily. There are a few people every now and then who can't go to sleep.
Are they just enjoying this? Is that?
Well, they're very tired. They're sleepy. And a part of our job in our technicians training is to make the patient comfortable so they can ease into sleep okay.
So there's no drugs involved in this?
We occasionally use drugs if we have to, but it's not our first choice.
You just want natural sleep.
We'd like to see them naturally.
Okay, so now you've run the test. You've seen something come out on a graph. Now what's the next step?
So depending on what we see, it takes sometimes a day or two to get all the data scored. It's a large amount of scoring. We have specially trained technicians who score these tests during the day, and then the physicians review this, and then we have the patients come back, review the data, and then decide on therapy if needed. If it's a medical problem like the abnormal REM behavior, medication's the treatment. If they have a sleep and breathing problem, if that's a mechanical problem, they may need a mechanical solution. So we go through that process.
I guess the second one that you mentioned, that's sort of like this thing called sleep apnea?
Correct.
Why don't we just describe that, just not briefly, I mean just do your full instruction on what that is.
So it's sleep apnea. Apnea means lack of breath in Greek. So lack of breath when you sleep. The most common is obstructive sleep apnea, which is a mechanical issue when the back of the throat, there's too much tissue back there, just the way the person was made usually. That when they go to sleep, that tissue relaxes and collapses into the back of the throat. The back of the throat's a very small area, and we ask it to do a lot of things. We ask it to phonate, to speak, to swallow, to protect our breathing pipe from things coming down in our lungs we don't want, all in a very, very small area. So during the day, all those tissues are highly charged. They're like your muscles when you work out.
Like right now.
Right now.
Right.
But when you go to sleep, all those same tissues relax. And they may, if there's not enough room back there, collapse and obstruct the breathing pipe. And so consequently, your brain figures that out during the course of sleep and struggles to get that breathing pipe open. That irritates your brain, so you don't get the deep levels of sleep you need, and you can feel tired from that or not rested. It also is a long-term risk factor for high blood pressure, heart attack, stroke, weight gain, increased blood sugar, anxiety, depression, just to name a few things. So, and then the treatment, because it's a mechanical problem, the typical treatment is some sort of mechanical solution.
Is this a permanent solution? I mean, no, let me rephrase that. Can you get someone like that to be normal?
Yes.
I mean, using the word normal, I know, but yeah, where they don't need any assistance. That's what I'm trying to say.
So is there, what I think you're asking me is can we do something to them to make it so they'll breathe and sleep correctly without any assistance?
Correct.
There's a small percentage of folks who may be able to have a surgical intervention, but that percentage is quite small. Most folks need some ongoing therapy that they wear when they go to bed. So that could be a mouthpiece that's like a retainer, a specialized retainer that we have dentists make for patients that pulls their jaw forward, keeps their throat open. The most common...
So it's like they bite down on it?
They custom make it for their upper and lower teeth. It fits over very thin, hard plastic. It pulls the jaw forward mechanically. It's adjusted so that it exerts pressure, pulling the upper and lower forward and opening the space in the back. The most common treatment's positive airway pressure. It's a very elegant solution, although patients who use it sometimes don't think it's so elegant. But we put air through the nose and mouth, and it pressurizes the back of the throat and acts like an air splint to keep the breathing pipe open. So we tell patients when they get injured, and you've had some experience with broken bones, an air cast holds those bones in place so you can put the real cast on. We basically are putting an air cast in their throat, but instead of air on the outside holding it together, it's air on the inside pushing it out. So that's what positive airway pressure does. Surgery, sometimes they can go in and remove certain tissues to make it better in the right patients, but they have to be highly selected. Sometimes body position.
You need that tissue in there.
Sometimes you do, yeah. And then sometimes body position. We'll have patients that simply do this only on their back. So we have some either tricks, so to speak, or mechanical devices like bumpers and tennis ball t-shirts and things that'll keep them off their back. We want the least invasive, most conducive thing for the patient. There's actually some new technologies coming out that'll be out in 2013. One of those is, instead of pressure going in, is actually a type of vacuum or suction device that will be inserted in the mouth, which will pull the tongue forward during sleep. So with this development of our field and discipline, you're starting to see more creative solutions come forward.
Now, the solutions you're describing seem quite, to my way of thinking, difficult in terms of being able to sleep. You're actually talking about having various tubes that are in someone's mouth, right? How do your patients react to this? I feel, knowing me, I might have some emotional difficulties with this. So typically, how do you deal with that?
Well, that's really actually the most critical question probably in dealing with a patient. Our first line of defense in encouraging patients is what we just went through. What you and I just discussed is the educational process we go through with almost every patient, so that they truly understand what we're looking for, why we're doing what we're doing, and how they're going to engage in the process. So what we tell patients frequently, Lee, is we're asking them to do something that's really difficult that no other physician asks them to do. We're asking them to participate physically in their care. And so we want to engage the patients in the process. Frequently, most of our patients are actually pleased at the end of the day with a good outcome. We will have some patients that either have physical things, for instance, their gag reflexes, or they have a mechanical issue, or they're claustrophobic, and we have to try to deal with that. And we try to adapt the therapy to them. We don't necessarily expect the patient to adapt to our therapy, but our success rates are quite high. There isn't any therapy that's 100%. So that's why people continue to try to develop new techniques.
Is this very common? We hear about it because of the media. It hits the newspaper. I'm talking about the term sleep apnea is in the papers. We hear it in the news sometimes even makes it into a TV show or a movie. But is this, I mean, out of 100,000 people, how many folks might be in a position to need the services of a sleep institute?
Well, there's two questions in there. One was sleep apnea, and one's needing the sleep lab or the sleep institute. Sleep apnea is the best numbers we have. We suspect are underestimating the degree of sleep apnea. So when you start talking about 5 to 10% of the population.
That much?
Yes.
So that's like, we're talking 15 to 30 million people.
And we believe that actually underestimates it because it increases as people age. And of course, we have an aging population,
yes,
slowly but steadily. And it increases with other disease states. So for instance, if you have diabetes and high blood pressure, the rates of sleep apnea with those comorbidities, as we call them, is very high, extremely high actually. So some studies approaching 70%. The other kind of illnesses are behavioral illnesses. So we talked about one, which is this REM abnormality.
Yes.
The most common would be things like insomnia, the inability to stay asleep or get to sleep, and then have difficulty during the day. That approaches in many studies anywhere between 9 and 11% of the population. So it is a very large percentage of our time on this earth. A third of it is spent sleeping. We're starting to see that the number of problems we're finding with that period of time are increasing to approach those of other disciplines like the heart, the diabetes, high blood pressure, etc.
I see. I want to go over and start talking about, what do they call it? Restless leg syndrome.
Yes.
But before we do that, I just want to ask one other question about sleeping. There are, in the media, stories about people who can get by on 10 minutes a night or an hour or 2 hours, you know, people who don't sleep much. Is this true, or are these people do they just have adaptive behavior and then collapse it for long periods of time later on?
I would have to say that you're correct on both accounts. Is it true? There are a few people that have that sort of biology. The amount of sleep we need, the amount of sleep to be healthy that we need, is determined at the time of our conception. Mm-hmm. It's a genetically made issue.
And what's that range?
The range
per day?
The range is typically between 6 and 9. Okay, it's just like when you used to grade papers, or, mm-hmm, and I know you were always in the A side of the curve, but the curve, it's the C level, is about 7 hours 45 minutes. It's, mm-hmm, a bell-shaped curve. Only about 1% of people can get by on less than 6 hours sleep. But the people who claim they can get by on less than 6 hours sleep, I would propose to you, is quite a bit larger than that. Mm-hmm. So those folks are frequently depriving themselves or trying to cheat the sleep, as we say, in order to accomplish something else. And there usually is a price to pay for that.
What is that price?
So the price can be long-term health consequences. Some derangements of sleep carry with it increased rates of cardiac disease. We're starting to see now high blood pressure, increased blood sugar, weight gain. There have been some reports of increased cancer occurrences. And so you're starting to see it affect each organ system over time. These are longitudinal issues. In the short term, the most common thing that we see is the same thing we tell our adolescent children. They get immunologic problems, right? They get, this time of year, they're getting illnesses. They get skin eruptions and acne, things like that. Some of the most well-documented abnormalities from not quality sleep, either too little or too disrupted, are immunologic.
Mm-hmm.
So,
is it true that, I mean, there's been reports that I've heard that when you're sleeping, it kind of cleans, it acts like the liver, the brain it gets cleared out of all this gunk?
Well, we don't know exactly what goes on. We do know the function of sleep that appears to us across all species is rejuvenation. And so yes, there is this, we think this, if you want to call it a clearing effect, but it rejuvenates us. It makes us feel better to function during the day. So if we looked at our main goal of sleep, the main goal of sleep is so we can be alert and highly functioning during the day. Mm-hmm. It does appear that sleep does some other things. For instance, memory consolidation, allowing us to have emotional balance, judgment, those sorts of things clearly are improved with quality sleep. And our sense of vigor is also clearly improved.
Well, I can speak to that. You get a good night's sleep. About the last 3 minutes here, let's just talk about this restless leg syndrome, which nobody had ever heard of 10 years ago, and now it's much more in the news.
So restless leg syndrome is a very interesting thing. It is a patient-driven syndrome. So there isn't actually a test where you give someone a test and they say, oh, I have, we see your legs moving. There are limb movements with sleep. We call those periodic limb movements of sleep. But a person who has restless leg syndrome, when they're going to bed or during the day when they're awake, feel the urge to move their legs, pain or discomfort in their legs, and have the urge to get up and sometimes rub their legs. So if this is going on, we typically check their blood iron levels, because that's something we can fix, which is associated with resolution. It can be seen in things like pregnancy and kidney disease. And then now the reason you're hearing more about it, I suspect, is we're learning more, but there are new medications coming out to help.
So this is real. It
is real.
This is not like a psychiatric issue.
It is not a psychiatric issue, and it can be very debilitating. People that have it, it can overtake them, their lives. It can be quite disruptive.
When you first heard about this, did you believe it?
Yes. Patients are...
First time that you heard about this, you said, this is nuts. You know?
No, the patients who have this can be severely impaired. And they have a wonderful... There are some patients... patients come to us in a way to be lifted up, Lee. Mm-hmm. These patients lift us up. They're so pleased and so improved after they've had therapy. And the therapy is so simple. It's typically medication. It's really exciting. Mm-hmm. But sleep patients are generally like that.
In the last minute or so here, is there anything that you would like to cap this off with?
Well, one, I think for your audience and to see the great changes that are going on, we're now doing testing at home for some sleep disorders, which is relatively new technology. So we're giving patients more options. They can come to the laboratory, which we need them to for some things. We use technology at home for other things. Medications are broadening, devices are broadening, and our intellectual capabilities to both talk to patients and give them solutions behaviorally are growing every year. Mm-hmm. And I think that's an exciting hope for our patients, because our patients are our friends and neighbors. Mm-hmm.
Now you have 30 seconds. You have the Sleep Institute here in St. Louis. People are watching this on YouTube. Will they find other sleep institutes around the United States?
They will. There are sleep centers and laboratories all around the United States now. We operate 8 within the Midwest region, but they're all over the country. I would look for things that are accredited and for board-certified sleep physicians. And there's no secret on knowledge. The knowledge is out there to help them.
And if they Googled, what would they Google to make sure they get the right place?
They should look for either sleep medicine centers, board-certified centers. Go to the American Academy of Sleep Medicine and the National Sleep Foundation, are 2 reputable sites.
Thank you very much.
Thank you for your time.
You're very welcome. I've been speaking with Dr. Joe Ojile from the Clayton Sleep Institute. I've learned a lot. I hope you did. For the rest of you who are regular viewers, we'll see you next time. And you can see this and show it to your friends on YouTube. Thank you.